Okay. As per usual, my battery ran out before I thought, so I guess that was a good time to stop. So this is part 2 of neurology. We'll start back with acute versus chronic glomerulonephritis. So the difference is acute starts very quickly, often after an infection, and some signs and symptoms. And this just makes sense. Your signs and symptoms are going to be a puffy face. You're going to get edema everywhere, periorbital edema up around the eyes, hematuria, either blood in the urine, or sometimes they can have brown urine. They're going to start spilling protein. The word for that is proteinuria. Oliguria is they're not peeing at all. That's less than 30 mLs an hour is oliguria. Anuria is 0 urine at all. Those are the patients that have to start hemodialysis or peritoneal dialysis. They can have fever, chills, nausea, vomiting, weakness. Their skin looks bad. They have shortness of breath. You're not supposed to say SOB anymore because it sounds like SOB, but it stands for shortness of breath. I just did that because it's saving some space on my slide, but don't use that word in clinicals. Headache, high blood pressure can lead to high blood pressure because you're retaining all that extra fluid. Flank pain. Typically when people say they have flank pain, that's a kidney issue. But in reality, your kidneys are kind of more up in here. And then in chronic glomerulonephritis, it's much more insidious. It comes on very gradually, quietly. It can lead to complete renal failure. And again, you have similar symptoms. It just is a little bit more of a gradual progression with the hematuria. The difference here is the urine can start getting foamy and bubbly. People don't want to eat. They start losing weight. They are having muscle cramps at night because any patient who has kidney problems can start running into some fluid electrolyte challenges as well because the kidneys aren't working like they're supposed to. Now, this is important. When your patient has renal disease, you have to know if it's a pre-renal cause, an intrarenal cause, or a post-renal cause. That's hugely, hugely important. Okay, so we're going to talk about that, but I want you to know this. So a pre-renal is a problem before it gets to the kidneys. An intrarenal problem is a problem with the kidneys. There's something wrong with the kidneys. And then post-renal is there's something wrong with the bladder or the ureters causing the kidney problems. That's really, really, really important for you to keep in mind as we go through the next part of this conversation. So in your pre-renal causes, it can cause kidney problems, but the reason it causes kidney problems is typically because the kidneys have not received the amount of blood that they want. Like I just said, the kidneys get a tremendous amount of cardiac output. I believe it's about 20% of the cardiac output goes to the kidneys. So if your patient has sustained an MI and their cardiac output drops and those kidneys are not getting as much blood, kidneys aren't going to be happy. So your myocardial infarction, your burn patients, remember, because of that massive hemoconcentration, major fluid loss in the burns, the kidneys aren't getting the blood they want, they're not happy, they're going to start acting up. Sepsis, same thing. Remember, in sepsis, the organs are not getting perfused like they need to be. Kidneys aren't getting perfused, they're not happy. Hypovolemia, same thing. The kidneys are not getting the oxygen that they need. All of those are pre-renal causes, but it can significantly affect the kidneys. It's like ischemia to the kidneys. So then the kidneys start dying because they have not gotten the blood that they want to. So in these scenarios, it is essential to maintain your patient on high levels of fluid. So typically what they do is they will bolus the patient, give like a 500 mLs, over an hour, 2 hours, and then give them on a maintenance fluid just to, reboot the kidneys. There won't be any protein in the urine because the actual kidneys themselves, there's not a problem with the glomeruli. It's a problem of amount of blood and oxygen that have gotten to the kidneys, not damage to the internal structure of the kidney itself. And then I'm going to wait on the intrarenal because this is the big one. And then post-renal would be things like bladder cancer, prostate problems, so that the urine can't get out. It starts backing up. Maybe a kidney or a stone that's stuck in the ureter. It starts backing up, causes bladder pressure, low flow, difficulty urinating. Those can then trigger kidneys to not be happy, but it's not an actual problem with the kidneys. So let's focus on intrarenal kidney failure. So in intrarenal kidney failure, the problem there is an actual problem with the structure of the kidney. And so what happens in intrarenal kidney disease is the tubules themselves are starting to get destroyed. And this can occur from any of the actual kidney problems like polycystic kidney disease, the nephrotoxic drugs that kill the kidneys, kidney failure. And what happens here is in intrarenal disease, the urine will have protein in it because those tubules are the things that keep the protein and sugar and the casts and debris. Those are all maintained within functioning tubules. And when those are not working, you'll start getting casts and debris in the urine. And the blood-specific gravity and the urine-specific gravity will be equal because of a destruction in the tubules. That's called acute tubular necrosis. I think I have a picture. I do. Yeah. So this is your normal tubules. Remember, this is like the Bowman's capsule that I was just showing you. So the stuff, the arteries come in through here. There's an exchange of toxic waste, fluids, electrolytes, all that stuff is going on here, and it's getting filtered down this convoluted tubule that I just showed you. Well, what happens in intrarenal failure is the tubular epithelium here, the basement membrane, start getting destroyed. And that's what I mean by an intrarenal problem. The structures within the kidney themselves are becoming damaged and destroyed. And ultimately, in end-stage renal disease, you'll start seeing all of this destruction. And so this membrane that was supposed to be intact is not intact. And you get debris and casts in here. And then you get exchange between the urine and the blood in here, which is why you have such problems both with high uric acid and urea in the blood, and all this cast and debris that gets expelled in the urine. So that's an intrarenal problem. And again, you can have acute renal failure, and it's a little bit like glomerulonephritis, but the glomerulonephritis is like kind of the glomeruli themselves. When we're talking about actual renal failure, it's a failure of the entire renal system. So there's two different kinds. There's chronic and acute. So we're going to talk about acute first. Acute renal failure, again, will come on very quickly, and it's often associated with something else, like a burn or a previous infection or something like that. Hypertension, hypovolemia. These would be like your pre-renal problems can lead to acute renal failure. So sometimes when a person is going into acute renal failure, if you can identify it early and you can start supporting the patient, giving them fluids, rest, things like that, the kidneys can recover. So you're going to see some things like major electrolyte shifts. The patient will start becoming acidotic. They will start having fluid retention. You need to know signs and symptoms of that. Rales, crackles, edema, things like that. And the elevated renal labs, you should know this by now because I've said it about 1 million times. And there's different phases of this. There's like an initial phase, which is when the problem is starting to occur. Then there's an oliguric phase, a diuretic phase, and a recovery phase. So we're going to talk a little bit about those. I'm not going to read these, but if you haven't already read them or wrote them down, just stop the video and then write those things down. Here's the stages of acute renal failure. The initiating thing, this can last for a couple hours, maybe a couple of days. When the kidneys are starting to identify, oh, there's a problem. The patient may have been hypovolemic for a while. The patient might have have some kind of an infection, but the kidneys are starting to not be happy. Then what happens is they go into this oliguric phase. Now, the thing to remember with acute renal failure, this is different than chronic renal failure, is the nursing responsibilities in the patient who's in an oliguric phase is completely opposite than when they are in the diuretic phase. So you need to understand the pathophysiology. So in the oliguric phase, this is caused by a reduction in the glomerular filtration rate. The glomeruli that I just showed you, the filtration rate is starting to drop off. In each kidney, you have about 1 million of those glomeruli that I just showed you. Well, what happens is those start failing. And so when those start failing, when they start dropping off, you're going to see the patient's urine output is going to start decreasing. That's called oliguria. So this phase usually lasts for about a day, maybe up to a week after the initial insult. But sometimes if it's mild enough and the patient was healthy enough, they might not have this oliguric phase at all, which makes the diagnosis a lot more difficult, and then you might not be able to identify it until it's too late. The key with this is identify it and treat it early, because the longer it lasts, the worse the prognosis is. So this phase typically will last maybe up to 2 weeks. It can last longer in your patients who have other comorbidities. But while the patient is oliguric, it is important because they are not peeing. So we are going to limit fluid. This is not the time when we are going to increase fluids in our patient because they can't excrete it because their glomeruli aren't working. So the rule of thumb is you monitor output. So let's say a patient who's in the oliguric phase, let's say they had, maybe 200 cc's, 200 milliliters of urine output the previous day. Then our natural bodies will also get rid of about 600 milliliters of insensible water loss. That means the water that is expelled with every breath, perspiration, sweating, things like that. You just lose about 600 milliliters a day from insensible water loss. So if the patient had a urine output the previous day of 200 milliliters, you would add 600 milliliters to that. So the following day, they would be allowed to have 800 milliliters of fluid as an intake. And so you have to factor that in if they've got an IV in. And a lot of these patients, you would just put the IV to keep open or a hep lock or something like that. They don't even get IV fluids because they can't get rid of the fluid. So you're worried about pulmonary edema in the legs and things like that. So it gets to be pretty tricky if the patient can't get rid of fluid. So after the oliguric phase is starting to subside, it's starting to get better, then the patient goes into the diuretic phase. And you know they're going into a diuretic phase because now all of that fluid that is retained in the body is that now they're starting to excrete it in the diuretic phase, and they start to lose a tremendous amount of fluid. The problem is the kidneys cannot yet concentrate that urine. So they are starting to get rid of excess waste. That's great, but the urine is not concentrated, so they're just flooding all the electrolytes, all the fluid, everything. So now you're doing the exact opposite. So now you may have to give the patient tremendous amounts of fluid. Monitor their electrolyte status. You may have to replace potassium and sodium because if those things get too low, you can also have cardiac problems if they're getting too low. You can have neural problems if your sodium is getting out of whack. You can have muscle problems if your calcium is getting out of whack. So really have to be careful that you're monitoring the electrolytes. I don't know what I said. So anyway, yeah, this phase can last for a while, which becomes a nursing challenge to try to keep up with the fluid management. So now we're up to, anywhere between 1 and 3 months, sometimes longer, depending on if your patient has any comorbidities. And then the recovery phase starts. So then in this recovery phase, those glomeruli start to improve. They start to, the membranes get back together, the glomerular filtration rate starts to work like it's supposed to work again. BUN and creatinine start to come within normal limits, so those glomeruli now are starting to excrete urine. They're able to keep it within those glomeruli and it's not excreting out into the bloodstream. And major improvements can start occurring. Your patient will be weak. However, this can sometimes take up to a full year to completely recover. And again, there's a wide variation here. If you've got a young, healthy patient, this is going to be a lot shorter duration compared to an elderly who has a lot of comorbidities. So that's acute renal failure and the different stages. Then we look at chronic renal failure. Chronic renal failure comes on over a period of time. There's 5 different stages to chronic renal failure, and there is no cure. So when a person starts developing chronic renal failure, this is why we try to prevent it in the first place. You've got to identify all those things that are affecting the kidneys. You identify those because you really want to prevent chronic renal failure. So in your patient who has chronic renal failure, diet is hugely important. You need to avoid potassium-containing foods because these patients tend to have high potassiums, which, as we know, we just talked about, can lead to cardiac problems. So you need to be careful because you want them eating healthy, but lots of fruits and vegetables are high in potassium. So you really need to be careful with that. Another thing that we are careful with in our kidney patients is protein, because the byproduct of protein is uremic acid. And so normally a person can eat protein and then get rid of it. It gets excreted through the kidneys, but in a patient whose kidneys aren't working, that uremic acid will just start building up and can make the situation significantly worse because they're already unable to get rid of uremia. Another thing that we do in our chronic renal failure is what we do in the oliguric phase with our acute renal failure patients is you do this 24-hour intake 600 milliliter rule, like I already talked about. They do tend to gain, retain a significant amount of water and sodium as that glomerular filtration rate continues to drop off. Another thing that your kidneys do is produce erythropoietin, which helps improve red blood cell production. So sometimes your patients whose kidneys aren't working might need to have shots of erythropoietin to kind of stimulate and increase the red blood cells and support the patient's health while, because they've got chronic kidney disease. They tend to also have high phosphate levels, and phosphate is found in calcium and dairy products, so you need to be careful with that. Chronic kidney patients, their diet is really, really tricky because you want them to have really good nutrition, but a lot of the nutrition makes the kidneys worse because of the byproducts of it. Chronic renal failure is such a problem now that patients who are diagnosed with chronic renal failure, especially end-stage renal disease, the healthcare, the government has recognized this as a substantial problem, and patients can go on, they can get long-term disability. They can get disability and Social Security for it, benefits for it, because there's no cure and they're unable to work and it's very debilitating. So there is some governmental help for that. So this is an example of chronic kidney disease, and you can see the kidneys just are not healthy looking kidneys at all. Uremic waste tends to increase in the bloodstream, and the patient can get uremic frost. It looks like they've got salt on their skin. They can get uremic pruritus where they're itching constantly. And again, that's because of the protein breakdown that leads to uremia. And then when that happens, it can also lead to sensory changes. They can get confused, lethargic, they can get some encephalopathies. And this is what's going on with chronic kidney disease. So, like I said, you've got about 1 million glomeruli in each kidney. So in stage 1 kidney damage, you can have greater than or equal to 90% of your glomeruli are still working. So you've lost about 10% of your glomeruli. This is not a big deal. A lot of people have this. Not a big deal. You might see a little bit of protein in the urine, maybe a little bit of sugar in the urine, but people are usually able to function pretty well in a stage 1. And then you can see all the way down here. So stage 2, now you're looking at between 60 and 89% of those glomeruli are working. All the way down in stage 4, we have a pretty significant drop off in that glomerular filtration rate, all the way down to about 15 to 29%. Of those glomeruli are working, but still the patient is, if you do really good nursing care, be really careful with their diet, be really careful with their fluid intake, they really don't need to be on dialysis until stage 5. This is complete kidney failure. The kidneys absolutely do not work, and those are the patients that need to go on dialysis. But that's not until you have like less than 15% of your glomeruli working. Those patients need to go on dialysis. So the next thing, this is a really bad picture, but it's a picture of end-stage kidney disease. You can see how swollen and large they are, with a lot of inflammation and bleeding in there. That's end-stage kidney failure. So now I wanted to talk a little bit about dialysis. So once your patient's kidneys are completely shot, they are absolutely not working, you have to do something to get that all that waste, the extragenous waste, the nitrogen. You've got to get it out because somebody will die. You cannot. It's like living, in your toilet bowl. You would die. You've got to get rid of that. So we have a couple different ways to do that, and we do that with dialysis, and that's done to remove excess fluid and waste. So hemodialysis is a process where taking out the blood in the venous system, the arterial system, they take it out, they run it through a dialysis machine, and the dialysis machine then will work as an osmotic agent. So it will pull out, it knows that there's high uremia, high potassium, high extragenous waste. So what it'll do is have a membrane over here with all low things, and by the process of osmosis, it will pull out all the waste products, and then it returns the blood back into the venous system clean with all of that stuff emptied out. So that is hemodialysis. This is usually done 3 to 4 times a week. Patients go to hemodialysis centers. Usually most hospitals will have a hemodialysis unit. There's a lot of outpatient clinics where patients can go, and they just sit like in nice lazy boy chairs. It usually takes 3 or 4 hours. These patients always have an arteriovenous shunt, and it goes in through a vein and an artery, and there's usually a fistula in between. Sometimes it goes up through the subclavian vein up in here. The shunts are done in surgery, but there's also some big catheters. I'm going to show you in a minute that works. These patients are at very high risk for lots of problems. The shunts can clot, the shunts can collapse. So as a nurse, if you work at a dialysis unit, or if you get a chance when you're in clinicals to go see a dialysis unit, it's pretty cool. You have to feel it. You can feel for a thrill, like you can. It's almost turbulent because the arteries and the veins are coming together. There's no capillaries. It's very turbulent, so you can feel that, and you can also listen to it and hear a brewery. You could almost hear like the heart beating, and those are good things. That means that your shunt is actually working. So as a nurse, you want to feel the thrill. You want to hear the bruise. So that you know that that's working. But you need to be very careful. The patients are high risk for infection because it's going right into an artery and vein. So they're high risk for anemia. They're high risk for fluid electrolyte imbalances. You need to be careful that when they stand up, they don't have orthostatic hypotension following hemodialysis. So there's a lot of nursing care goes into a patient on hemodialysis. The second kind of hemodialysis is called continuous ambulatory peritoneal dialysis, CAPD. This kind kind of dialysis is done through the peritoneum. And the patients, I'm going to show you a picture of it, goes in through the skin and right on top of the peritoneum, and then there's a diacylate that goes in, and the loops of bowel then actually become the membrane. Just like the hemodialysis has that artificial membrane, the bowel itself becomes the membrane for exchange. But the thing with peritoneal dialysis is they can't have any GI disorders, so they can't have Crohn's disease, diverticulitis, things like that, because indwelling the diacylate can cause some bowel obstructions. It can lead to some scarring. This is done at home, so if you're working in community health nursing, you will help teach a patient how to do home dialysis. It's usually done nightly. The patient will hook up their diacylate and they will infuse it slowly, usually over 20 minutes to an hour, and then they will indwell it overnight, and then in the morning they drain it out and they cap it off and be on their day. So these patients also have some risk factors. Okay, so this is what hemodialysis looks like. There's an AV fistula. Arterial is on the arterial side, venous, and so this is done in the operating room. The surgeon will actually insert it, or if it's over like in an arm like this, they'll put like a graft in, or like a fistula in, so that they're actually anastomosing the artery to the vein. This is a hemodialysis machine, and it's not a big deal because it's like a PICC line. It just sort of stays in there. These, you have to be careful with infection, so you keep it with like an adhesive Band-Aid on it. And then you go into the dialysis unit, and they just hook it up to the machine, so all of the blood that's going over here has all that waste product in it. It goes through these filters, and then all the stuff gets filtered out, and it comes back into the patient clean. So it's the patient's own blood. It's just this is the patient's kidney, so it's just removing all that stuff. So patients who are on hemodialysis are not peeing. They don't have a urine output. So you just monitor output in their hemodialysis unit. So it can be up here in the subclavian vein or in one of the arms. Do not, if a patient has this going on, you do not take blood in that arm, you don't take blood pressures in that arm, you use the other arm. This does become problematic because these do tend to clot off, and so oftentimes you're switching this back around. These people have horrible scarred up veins, but after they've been on it for a while. Okay, now continuous abdominal peritoneal dialysis, this is what this looks like. And you can see here, see all these scarring? This guy has obviously had his catheter switched around a lot because of probably scarring or infection or something like that. But this is the tube. This is what it looks like. You can see it's really long, and there's lots of big holes in it down here. So this is the diacylate, and what they'll do is the neurologist will figure out what should be in the diacylate, and it's all based on osmosis. So they'll put stuff in here that has a lower concentration. So let's say there's a bunch of uremia in here, they'll put no uremia in here, so that just by osmosis, the waste products will go here, and the good stuff like water or whatever they're low on will filter back in through here, and then it is just in these loops of bowel like this, and then in the morning they drop the bag down just like a Foley catheter and use gravity then to drain the diacylate out, and then they clamp it off and they can go about their day. The things that you watch for again are infections. So if this is starting to come out purulent, cloudy, foul smelling, that could be that the patient is developing a peritonitis. This is the peritoneum, and it's not uncommon for these people to develop a peritonitis. So you watch for fever, general malaise, increased white blood cell, and then if this is starting to look nasty, you need to address that immediately. So that's continuous abdominal peritoneal dialysis. Patients, that's a much more ambulatory thing. They can walk around with it if they want to.